we're very, very pleased to have Dr. Nakagawa here to give a presentation for SIPC. We're very excited about the work he's been doing. He's an associate professor of medicine at the Columbia University Irving Medical Center and director of our inpatient palliative care services and director of the cardiac supportive care services at NYPH. He has extensive training and background in general surgery, internal medicine, geriatrics medicine, and hospice and palliative care, both in Japan and the United States. His clinical and research interests are palliative care for the seriously and critically ill, including those with cancer or advanced heart failure. And he's developed palliative care consultation program prior to left ventricular assist devices implementation at NYP. He teaches palliative medicine to different levels of trainees, including fellows, residents, and medical students at the bedside. He is a sought-after lecturer and has been invited to conferences in Japan and the US, locally and nationally. And he has a strong commitment to teaching medical communication, such as how to break bad news, lead family meetings, and navigate difficult decision-making for the seriously ill. He received APGAR grant awards in 2017, and he co-developed the Communication Skills Practice Program for General Surgery Restaurant residents. So thank you, Dr. Nakagawa. I really appreciate it, and I'm looking forward to your talk.
Thank you for the nice introduction. So hi, my name is Shunichi Nakagawa. I'm a palliative care physician at Columbia, and so I have been here for, I think, 8 years, and I have been so lucky that I have been able to involved in the care of the heart failure patient, LVAD patients. And so today I'd like to talk about the most difficult part of this LVAD therapy. So let me get started. No disclosures. So learning objectives is I want to ask a couple of questions. How LVADs are different from other forms of life-sustaining treatments, and then how should clinicians approach to withdrawal of the LVADs? So congestive heart failure, very, very bad disease. Many end-stage heart failure patients in a terminal phase of the disease, and 50,000 patients with end-stage heart failure die in the US each year. And once you are dependent on the inotrope, that is a continuous infusion medication, 1 year mortality is very, very high. And the only way to fix this problem is a heart transplant. You need to replace heart. So these 80 to 150,000 patients every year could benefit from the heart transplant. However, the only 20 to 100 patients can get the transplant every year in the US. So this is the trend of the case number of the heart transplant. United States is in this the green one. As you can see, over the last 20, 30 years, the case of the transplant has not been increasing. It has been steadily about 20 to 100 cases. So this means that a lot of the patients dies without getting transplant. So this technology, left ventricular assist device, emerged to ameliorate this problem. So this is a small device. This is a pump, and then it is placed with open heart surgery. This is a left ventricle. This pump is attached to this left ventricle. And then this pump sucks the blood from the left ventricle and then pushes the blood forward to the aorta. And this pump needs power. So it is connected to the drive line, and it is coming out from the epigastrium. And then it is connected to the battery, the controller and the battery. So you need to be connected to the battery for 24/7. At night, you have to put that outlet, and then you need to be connected to the power. When during the daytime, when you walk around, you have to carry the battery all the time. Okay. So, so this is a part of the life-sustaining treatment. So by broadly, what life-sustaining treatment means, those are the measures which replace or support ailing bodily function. I think we are familiar with the mechanical ventilation, vasopressors, or dialysis. Kidney fails, we do dialysis. But this heart pump is the one of the life support. And the thing we have to remember is the important thing that in itself, it's not a treatment to fix a problem. It's a band-aid. When you have a respiratory failure from pneumonia, you put the patient in the breathing machine, but the breathing machine itself is not fix the pneumonia. Pneumonia has to be treated with antibiotics. So while we are buying time with this life-sustaining treatment, we try to fix the problem. So, sometimes we can do that successfully, but sometimes patients, organ function doesn't improve and patient cannot make it, or patient has to stay on this life-sustaining treatment for a long period of time. So in the case of the LVAD, initially it emerged as a bridge to transplant. We call it BTT. So we wanted to buy time by giving this device. So a patient who are listed for heart transplant and who no usual other medication or other medical treatment doesn't help. So we put the LVAD for this patient, and then we wanted to buy time. However, as I showed you, the number of the transplant didn't increase. So even if we give more time, still a lot of patients die before getting the transplant. In the meantime, we start to realize that, hold on a second, even if we cannot give them a transplant, by just putting this device, we can give them more time with better quality of life. So we start to place this device as a destination therapy. We call this DT. This is not for the patient who is not a transplant candidate. And the thing is, this device will remain in place for the rest of their life. This is called DT. And this, technology is amazing. Over the last 20 years, it has been advancing very, very rapidly. 20 years ago, it was much bigger, much heavier, but now it's much lighter, much smaller. And this is the trend of the case in the United States. Over the last 20 years, now, every year in the United States, more than 3,000 new LVAD implants has been happening. So how do they do? So this is their survival. 5-year survival, as you can see, over the 2015 to 2019, 5-year survival is 46.8%. So it's slowly increasing, so improving. So technology is advancing and the survival clinical outcome is also improving. Usually when you see, patient on life support, they look like this. They are lying on the ICU, tube in the mouth, and then they look very sick, lots of tubes. But, LVAD is a little bit different. This is one of the patients who had LVAD. He's 36, and this was placed at BTT. And then he had LVAD about like 1.5 years, and he got transplant. This one is another one. This patient got LVAD as DT. And I think he, at this point, when we took this picture, he was with LVAD for about more than like 10 years. So they look great. And this is another data to show the outcome. So, LVAD has made the impossible possible. Before this LVAD, OMM is optimal medical management. So without LVAD, the end-stage heart failure, their 2-year survival is like around 10%. But with this LVAD, it increased to like 70 to maybe 80% more recently. But when I look at this graph, I look at in a little bit different way. I look at like this, before these blue people have died, but now only these people died. And what's going on with these patients, those who die? The reason I say this is even if we do our best, you cannot avoid complications. Almost all of them are coming back to the hospital for whatever reason. They have bleeding, arrhythmia, respiratory failure, infection, stroke. So many, lots of problems come with as a side effect or complications with LVAD. And then even if we do everything, we cannot avoid these complications. So now I'm going to show you 3 or 4 cases. So let me start. So first case, he's 54 years male, past medical history of hypertension, diabetes, and he had a DT LVAD. And his hospital course was okay. It went well. He was discharged home in 2 weeks. But he had a problem with device thrombosis. So he had to come back after like 50 days. He was admitted, and then we did the device exchange. This is one of the surgery. I mean, we just exchanged the device. It was okay. And he was doing well 2 weeks after that surgery. However, all of a sudden, while he was, I think, getting close to discharge, he had a sudden mental status change. And we took the CAT scan. We found that he had a massive ischemic stroke. He was transferred to the neuro ICU. He was intubated. And it was very, very bad. It's significant neurological damage. And the family requested withdrawal of the LVAD. So please use your phone. So what do you think with this case? Should LVAD therapy be withdrawn? Many people say, okay, so yes, immediately like 60%. Too early, we should wait for a while, 40%, I see. But none of you said absolutely not. Okay. 56, 44%. I see. Great. Very good. Thank you. Thank you for participating. So I think that's interesting. Very good. And so what happened is, so when family requested withdrawal, based on that the situation, we doctors also think it's very appropriate. So actually, we proceeded with withdrawal, deactivate the LVAD on the same day, and then patient passed away on the same day. Okay. So with LVAD, how do they die? There are 2 ways of dying. One is, continue LVAD treatment until the very, very end. And what happens is, the blood pressure drops, and then there's a no-flow alarm goes off, and then we come to the bedside and we stop the LVAD. It can happen in the ICU who is on a multi-system organ failure. Patient is on multiple life support, but it also happens on a regular floor or home. The patient is the code status is general DNI, but that can happen. Another way is, patients and family make a decision to stop LVAD before that happens. In the same situation, multi-system organ failure, multiple life support in the ICU, and then also the, patient could be awake, and then patient could express his wish on his own, his or her own. And this is the one way withdrawal of the LVAD therapy. And then, this the first one, the continue LVAD at the very end, I think that illustrates the difficulty with withdrawing or deactivating the LVAD therapy. So now I'll go to case 2. This is the 71-year-old male. He had a history of coronary artery disease, ischemic cardiomyopathy, diabetes, and social history that he's widowed. He lives alone, but he has a daughter and son. He has 3 grandchildren. And, he was deemed a candidate for the LVAD therapy. So palliative care, we were consulted. Why? Because 2014, we started to consult all the LVAD patients before the surgery to ask to have a advanced care planning conversation. We basically asked these 4 questions. First is, what do you hope to gain from this surgery? And do you have any worries about your procedure and recovery for you? And are these conditions is there any condition that you'd find unacceptable? And how much, are you willing to go through for the possibility of living? And how have you discussed this with your loved ones? We try to ask these questions before the surgery to be better prepared. Why do we ask? I'll tell you why. These 4 questions are very important because, functional status, we can say this as a quality of life. This is declining of the heart because of the heart failure, and we are here and now talking. By having the surgery, quality of life functional status is going to decrease for sure. But in exchange, we are hoping to get back to where we were before. If patient dies, it might not be nice to say, but I think it's okay. We do everything and patient dies. I mean, you don't have to worry anymore. We did our best. The problem, the more difficult is, patient doesn't die, but doesn't get better. Patient could end up with, bed-bound or life support dependent, or even worse, patient lose cognition with bad stroke. So there's a lot of, gray area between, this is not black and white. There's a lot of gray area between them. And we need to, explore what is appropriate for this patient. So the question I told you, what are you hoping for? The answer to this question is going to tell us, how high this line is going to be for this patient. And the question, what are you worried about? And what is the condition unacceptable? This is the answer to this question is going to tell us how low this patient can accept, for living. And fourth question, how much trade-off are you willing to accept? Is going to tell us, the shape in this curve. So that's why we ask these questions. So what did he say? He said that what makes your life meaningful? He said, time with family. He likes car. He likes taking photographs. And what is the condition unacceptable? He said, I'm very independent. Becoming a bedbound or losing cognition, that's not the life for me. He said it very clearly. And he said that we had this conversation in front of the son, in front of the family. So we had this conversation before there was surgery. And also we tell all the patient before the LVAD, LVAD is a life support and it could be deactivated at any future point if it is not helping you. So what happened? So he went to the surgery. Unfortunately, after the surgery, he had some minor strokes. And he stayed in the ICU for about 10, 11 days. His function was okay, but it caused him, depression and also slightly decreased short-term memory. He was able to go home after less than 4 weeks. He went home, and he was at home, but 4 months later, he came back. He fell and he developed a subdural hematoma, and he had decreased mental status. And he was delirious, and he was not able to express himself. He did not have any decision-making capacity. So we had, after 2 weeks, we had a family meeting with daughter and son. So according to the neurology, they said that, right now he's delirious, but, actually this is not so bad. If we give him treatment, if we do the physical therapy, he could improve to the level where before this episode of fall happened. So that was the assessment by the neurologist. And what family told us is, however, doctor, since he came home, he was not engaged in the physical therapy. He was sort of withdrawn, and his cognition has, declined, and he was not able to, move around like in the past. So he was not so happy that's what the family expressed to us. So now, Paul, so what do you think? In this case and in this situation, should we stop the LVAD? Yes, immediately, too early, we should wait for a while. Absolutely not. What do you think? I see. So 20% of people said yes immediately. And it's too early. Many people feel it's too early. I see. Nobody think absolutely not. I see. Good. Very good. Thank you. It's interesting. Okay. So what happened is after we discussed, we explained that, even in the best case scenario, we can continue treatment, continue physical therapy, and we can give him more time, weeks or maybe a month or two. But even in the best case scenario, he could only get back to the level where he was before this fall. And then this, quality of life at that time was not even satisfactory for this patient. So, family was feeling that why do we have to let him go through this, difficult rehabilitation process? So with this conversation, we decided to deactivate LVAD. So we did that in 2 days, and he died the next day. So I think this was the case where, the conversation before the surgery was really helpful, the conversation we had. So when do you consider stopping LVAD, deactivating LVAD? LVAD are life support, and it was placed in order to achieve his or her goals. And this goal could be whatever. It depends on the patient. It could be, enjoying playing golf, or staying at home, or have time with family, whatever. There's no right or wrong answer. But sometimes things don't go well because of the LVAD-related complications, such as stroke, or multiple hospitalizations, or multi-system organ failure. And sometimes, LVAD can function perfectly, but in that case, you still have to face a different problem, such as, patient gets older, patient can have cancer, and then patient become overall debilitated. Patient get metastatic cancer with LVAD. So should we do the aggressive chemotherapy? That's a very difficult question. So we need to think, about the LVAD, when LVAD cannot achieve these goals. So, we drew this curve. So we have to think about this curve, along that way, all the way, through the trajectory of this, clinical course. Who makes the final decision? And, quality of life is, patient specific. So it decided only by a patient. But, if patient cannot express himself herself, those who know the patient best, so that family. However, because it's a huge step, deactivating everybody is a huge step. So ideally, all the parties, meaning, physicians, us, and the patient and the family. So these three groups should be on the same page. So, ongoing communication is very important, but, we are not comfortable with this situation. So I'll ask you a couple of several questions. So how comfortable would you be with turning off LVAD at the end of life? If patient is at the end of life, how comfortable would you be? Very comfortable, comfortable, uncomfortable, very uncomfortable. Okay, 70% comfortable. So 25% uncomfortable. This is not right or wrong answer. Okay, very good. Now, what is the cause of death after turning of LVAD? Is that euthanasia or physician-assisted suicide, underlying disease, or not sure? Okay. 14% suicide. Nobody thinks it's euthanasia. Okay, good. Now, any distinction between withdrawing LVAD versus mechanical ventilation? Stopping LVAD is okay, but stopping vent is not. Stopping vent is okay, but stopping LVAD is not. Or it's the same, both are okay. No, neither is okay. How do you feel? Okay, everybody is, it's same, both are okay. Excellent, excellent. Okay, so this is, so I took these questions from the study. So there's a survey which was done towards the, I think, heart failure cardiologists. So these questions are asked towards the cardiologists who deal with these problems, the LVAD patients all the time. So what did they say? So they said that, comfortable or very comfortable, only 28, 26%. So doctors are not comfortable. And what is the cause of death after turning off LVAD? So, 13% of the doctors feel that it is the same as euthanasia or efficiency suicide. And many doctors feel distinction between stopping LVAD and also stopping mechanical ventilation or IV fluid and nutrition. Okay, so this is, how the cardiologists feel. So yes, clinicians are very uncomfortable. Very common question we hear is it efficiency suicide or euthanasia? It is different from palliative extubation because he's awake. Or ICD, the defibrillator is to avoid the uncomfortable shocks, but isn't he dependent on LVAD? So he will die immediately. So that's different. Once device is integrated, is it part of the body? So these are the common sentiment we hear from the clinicians. So I want to go over the difference between PS or euthanasia. By definition, euthanasia is an act that intentionally causes death in someone who is very sick or suffering. PAS is a physician helps a patient in taking his or her own life by intentionally providing lethal dose of medication with knowing that the patient might commit suicide. So euthanasia, we doctors administer the medication. In PAS, we give the medication to the patient, but we know patient is going to take it to terminate their own life. So this is a difference. And there are two things that we think it is different. One is the physician's intent. PAS or euthanasia, our primary intent is to terminate the life. But in case of withdrawal, our intention is not to terminate the life. Our intention is to remove the burdensome treatment, and then not prolong suffering. That is our primary intention. More importantly, after patient dies, what kills the patient? So in the PAS or euthanasia, what kills the patient is the medication or intervention we provided. That is going to kill the patient. But in the case of withdrawal, mechanical ventilation or LVAD or whatever, what's going to kill the patient is the underlying problem like cancer or heart failure. So those things are the reason for the patient to die. So because of these two reasons, in the United States or in the Western countries, there's a clear distinction between these two, medically, ethically, and legally. So basic ethical principles is, as long as the burden outweighs the benefit, patient has the right to refuse any treatment, to request withdraw the treatment they previously consented. Even if they said, okay, I'll take it, they can take it back. So withhold and withdrawal is the same. And this right is not unique, meaning that withdrawal of the LVAD is the same as withdrawal of the ventilator or dialysis or other sort of life support treatment. So you cannot say, you can, but you cannot say, I'm okay with stopping vent, but I'm not okay with LVAD. Ethically, it should be looked as the same, as equal. So how the decision has to be made? who will decide? Like I said, patient decision is much more important than clinician decisions. Clinicians should not impose their moral views on patients. By what criteria? Benefits and burdens are determined by the patient. Each patient is unique and based on their own values and preference and the healthcare related goals. And requests can be made even if the patient is not terminally ill. So, clinicians should not be compelled if uncomfortable. So I said that, clinicians' decisions is, patient decision is more important than clinicians. But if you are not comfortable, that's okay. That's okay that you don't have to, participate in that process. But the thing is that you cannot abandon the patient. The last thing you should do is, no, I cannot do that. So you have to continue. That you cannot do. You have to look for some clinicians who can take care of that, like me.
Definition of a crime if you perpetrate an assault on.
So I want to show you the data from Colombia. So, LVAD withdrawals at Colombia. So we looked at the data over the last 8 years, 2010 to 2018. So during this period, 546 newly implanted LVAD we did. And from here, 143 patients died. So 26% of patients died. What do you think? How many of them decided to stop LVAD? There's no poll. Think about it. So this is the outcome. So roughly 44%, the green one, the 56%, they didn't stop LVAD. But the rest of them, 40% or so, the LVAD was stopped. And then among those, like 10%, 1/4, the patient had decision-making capacity and they requested to stop the LVAD. And 30%, 3/4, the patient didn't have capacity, patient couldn't express, and so family made a decision to withdraw. Okay, so when we look at this, we divided these two cohorts. Patient had capacity, but the patient didn't have capacity. So there are some trends. What we found was that patient couldn't express themselves. They had more, CV, the stroke, and acute trajectory means that the patient was doing okay, but all of a sudden, got a stroke and then got sick, like the, case one, example one I showed. So those are the more typical, picture. And then those patients tend to be sicker. They tend to be in ICU, and they tend to be on mechanical ventilation or on the dialysis. And patients who have capacity, they required more palliative care consult or ethics consult. So which illustrates that is more challenging. I looked at the time course, time before LVAD withdrawal. So patient who requested LVAD, what happens is, we put the LVAD at some point. Patient requested to withdraw the LVAD, withdraw. Usually we become uncomfortable. Family or I told you the patient and the family and the physician, there are three groups. And then a patient requested to withdraw. Usually, family or clinicians, our team, taken aback. At some point, but we come to the agreement and we stop the LVAD. And then these 14 patients, about like 6 days, 5-6 days, we need to come to the conclusion. In the case of the patient who does not have capacity, in that case, at some point, patient lose capacity, stroke or getting too sick, and then patient lose capacity. So typically, in these cases, we doctors start to think how long we should continue. Does it make sense to continue treatment? How aggressive we should be? And then we speak to the family, and at one point, the surrogate, the family, come to the agreement. And then during this period, it's about the same, like 6 days. I mean, this time frame is looking at a different thing, but I want to show you the some, what happens during this period. Then the also important thing is that where patient is located matters a lot. Specifically, if patient in the ICU or not in the ICU. The upper chart is this is a 14 patient. Patient had a capacity. So in this case, if patient is in the ICU and the patient has a capacity, and the patient says, "I don't want to continue this. I want to stop LVAD," we come to the conclusion relatively quickly. We agree. But if patient is not in the ICU, we are not comfortable. So we need more time. So 46 days. It was significantly different. In the case patient doesn't have a capacity, still if patient in the ICU, we come to the conclusion relatively quickly. Outside of the ICU, we need more time, but the difference, within or without, in or and out of ICU, this difference is much bigger when patient has capacity. So what this means is, takes longer outside the ICU, and then the difference is larger with patient request. So patient request poses more difficulty. So what this means is that in ICU, usually patient is acutely sick because of some catastrophic complications. Could be stroke, sepsis, multi-system organ failure, and patients more typically on ventilator or dialysis or different kind of the life support. Not in the ICU, patient is sick probably because of other reasons. Debility, could be stroke, old age, or multiple hospitalization, or could be from cancer. So in the ICU, LVAD is only one of the life supports. And then outside of the ICU, LVAD is the only life support. So it also, adds the difficulty to the situation. So because of that, I think outside of the ICU is more difficult in terms of comes to decision making. And because I think suffering, quote unquote suffering, is I think much more obvious in the ICU compared with outside of the ICU. So I'm going to talk about case 3. So this is a 78-year-old male. He had a heart failure, COPD. He had happily married for 50 plus years, 3 children, 7 grandchildren, 7 great grandchildren. Wonderful. And the clinical course, he had a LVAD as DT. He was doing okay for about 3 years, but he started to have more shortness of breath and physical debility after 3 years. And in another year, he started to express desire to deactivate LVAD. So he asked, is it possible? So I was consulted. So I saw this patient in the clinic. So he's not admitted. I saw him in the clinic, and then I met with the patient and the wife and daughter and son-in-law, 4 of them. And I asked him, so why do you feel that way? So reason why he wanted to deactivate LVAD, he decreased exercise tolerance, increasing difficulty in ADLs. It's most burdensome. He said, I'm used to be very independent and able to do things by myself, but now I have difficulty even going to the bathroom. I have had enough. He said multiple times during the encounter. So this is a situation. So what do you think? In this case 3, should LVAD therapy be withdrawn? Yes, immediately, too early. We should wait for a while. Absolutely not. Wow, many people say yes immediately. I see. 69%, 31%. Okay, good. So, okay. So what happened is we didn't do that immediately. He's not acutely sick. So what I did was, we explained the deactivation process, and we made him DNR DNI. Basically, I said that, Mr. So-and-so, we understand. I understand. I hear what you're saying. I know you're suffering. But, this is the very, very, huge step we're going to take. We cannot take it back. So, if you feel the same way, we can do that definitely. But before going to that step, why don't you, talk to your family? If you feel the same way in a month or two, we'll do that. In that case, we'll admit you in the hospital and we'll make sure you're comfortable and we can deactivate it. So I explained the process, what is going to happen if we choose that way. And then why don't you give it a thought? So, but in the meantime, if he gets sick for whatever reason, it doesn't make sense for him to go to ICU, get intubated. So I made him DNR DNI, and then I recommended to give it a thought. So he agreed. And then in 2 months, he contacted us. And he said, doctor, I spoke with my family. I feel the same way. And then I spoke with the daughter and then the family. And then they said the same thing. We love him. We don't want to lose him. But it's also painful. It's also painful for us to watch him this way suffering. So I don't want this to prolong. So we agreed. So we came to the conclusion. And then we deactivated LVAD the next day, and he died in 3 days. So this is case 3. So we have probably 10 minutes. So now I'm going to tell you the most difficult case I experienced, case 4. This is 55 years old male. He was diabetes, he has heavy smoking. But, he's pretty independent. He's very active. And he has been married. He has 2 children. He lives in New Jersey. I mean, because of this lecture, I'm changing the details for the HIPAA. But I wanted to give you some picture. He's very successful. He retired. He's, financially well off. And he had a heart attack. He was doing totally fine, but one day he had a heart attack. He came to the hospital. He had a surgery, and he developed a cardiogenic shock. So when he woke up, he was in the ICU, and then he needed the LVAD in order to survive. Otherwise, he died. So imagine he was doing okay, but he crashed and he woke up, and he had to choose LVAD or death. And then I went to talk to him, but I asked, do you have any condition unacceptable? Of course, I don't know. Don't ask me that question. Yeah, I think I hear you. You cannot answer this question, fine. So we did the surgery, and then the problem is that he had a stroke right after the surgery. And he was discharged. He stayed in the hospital about 1 month, but he discharged to rehab. He had to choose the LVAD, but he was hoping to get a transplant in the future. And he went to acute rehab, but he was very independent, strong personality. He was very grumpy. So he refused the medical care. Sometimes he refused to go to rehab. And he finally went home. He diligently did physical therapy. He was able to he was very debilitated. It was difficult for him to transfer from wheelchair to bed. So over the next 2 years, this was LVAD implant. He was discharged home after 1 month. He came back once because of another stroke. He left the AMA. Second time he came because it was some suicidal ideation. He was agitated. I think he was trying to stop the LVAD. We called the psychiatry, he calmed down, and then he was discharged home. But throughout this process, and then also, sorry, he also admitted with device thrombosis, and he had device exchange. So it has been going on for more than like 1 year. During this period, he worked on physical therapy very diligently because he wanted to improve and he wanted to get transplant in the future. However, after discussion, it came to the conclusion that we cannot do the, he's not a transplant candidate. As soon as he heard this, he came to us saying, I want to stop LVAD. He's not sick, he's at home, and I saw him. Right now, at that time, he's independent in ADLs. He walks with cane. No significant symptoms, no pain, no shortness of breath. He spent time at home. He doesn't go out. Also, because of stroke, his vision was not good. And then, he says, the current quality of life is not the level of the one prior to MI. And he said, I cannot go on like this for the rest of my life. This was very strong. If I knew what I know now, I would not have done LVAD. If I knew of no heart transplant, I would not have done device exchange. So, he had extensive conversation with the family, and he knows, I know that my family doesn't like this. I mean, they don't want to lose me, but they are financially okay. They are not going to be in bind. So, this is my life. I'm okay. I want to stop the LVAD. So what do you think? Yes, immediately 60%, too early, 44%. Okay, so 50-50 about, great. So questions are, is he really serious to stop his LVAD? So, when patient is not in the ICU, patient is not in the hospital, patient in the clinic, patient is at home, we need to make sure, this request is consistent. We have to think that this patient has decision-making capacity. Can we find, compromise? Or what else do we need? If he's serious with clear decision-making capacity, are we willing to accept his request? He's not end of life. He's not acutely sick. Is it okay to let him die? So I made a recommendation, can Dr. So-and-so, Mr. So-and-so, why don't you wait for, like 1 to 2 months? I want to make sure that, we're on the same page. We don't want to take the quick conclusion. And he said, okay, I hear you. So 2 months, that's a maximum. I can wait. I can give you 2 months. And why don't you go through the transplant evaluation in other institutions? He said, no, I don't want to do that. You are Columbia. You are the best institution. If you say no, other institution is going to say no. And he's right. And we asked a psych consult, why don't you see psychiatrist? We need to make sure, you are not depressed or you are not sick. And also some treatment might make you feel better. But, he had seen psychiatrist as an inpatient, and also he was very clear, I don't want to take any medication to have effect on my mind. So that was in July, and this is the first I met. And then after 2 months, I met with him again. He feels the same. From your perspective, this is what he told me. From your perspective, it is not so bad. But that is your doctor's opinion, not mine. And you can try change my mind, but good luck. It won't work. I have my decision already. I have control on how I feel. I feel worse than before, like before 2 months ago. So he agreed to see psychiatrist, and he was depressed, but still he did have a clear decision-making capacity, and the patient didn't want any treatment. So patient remained consistent for this, I think, 3 months. And I spoke with LVAD team. I spoke with ethics committee. Initially, they don't think it is a good idea. We should not do that. If he's too sick, I mean, he might not understand what he's talking about. But this, throughout the process, after, he's suffering. His presentation was acute. I mean, this is the argument I made. His presentation was acute like two years ago. Without any CHF experience, he faced the crucial decision of LVAD, and the stroke made his quality of life significantly worse. After 2 months of hospital stay, his lifestyle changed dramatically. And he tried what he could do to improve his quality of life. Physical therapy, he was very compliant. He took medication. He did cataract surgery to try to improve his vision. And then for the hope to get a transplant. So, and I thought, isn't this the most informed decision? This is what he said. If I knew what I know now, I would not have done the LVAD. If I knew of no transplant, I would not have done the device exchange. So, even though he doesn't look like so because of the LVAD, he has, at the end of the day, he has end-stage heart failure. So we had extensive conversation, and then we came to the agreement. And yeah, he is suffering. We should respect his wish. And we made the coordination, and then we admit him, and then we deactivate the LVAD, and he died. And what was striking was he told me that don't talk to my family before this making a decision. So I couldn't talk to family. After he died, I went to the bedside, and then I gave my condolences. So I thought, family hating me because by advocating for him, I was kind of helping to take him away from the family. But actually, family was very appreciative to me. I mean, they said, thank you for doing this. I mean, they said, he was crying. He was crying at home because he was not happy. He feels sad. So it was, I mean, they didn't want to lose him, but at the same time, it was so painful for them to watch him that way. So I showed you the same. So, we should come to the agreement, these three parties, patient, family, and physicians. I showed you 4 cases. Case 1, no cognition in ICU. Case 2, delirious and patient on the floor. This was not so difficult. Case 3 with capacity, but debilitated and the shortness of breath at home, it took 2 months. But in case 4, the last case, it took like 3 months, and there are lots of conversation. So my point is that, depending on the situation, extra caution should be taken before making a final decision. So conclusion is that, given the characteristics of the LVAD therapy, withdrawal could pose unique problems. And however, the basic ethical principles apply as the other form of life-sustaining treatments. And goals and values need to be revisited regularly throughout the clinical course. And in withdrawal of the LVAD therapy, close communication among patient and family medical team is essential. This is my talk.
Dr. Nakagawa, thank you so much. It's just wonderful. Really a very thoughtful presentation. The chat has not been super busy, but a little bit. And I think you covered some of the questions and the thoughts. But after case 2, Peter Shapiro thought, the LVAD was not that burdensome. It was a stroke, the limitation, and that the patient's intention was to hasten his death to remediate his reduced quality of life. I said, but wasn't the LVAD didn't help as much as he hoped for. He said, but isn't that the distinction between withdrawing the LVAD because LVAD is burdensome and withdrawing LVAD because life's problems are burdensome?
Right.
And
I mean, correct. I think the LVAD treatment itself is not burdensome. It is not causing any harm. It is not causing any pain or anything. But the quality of life, the functional status for the patient, even the best case scenario, that's not acceptable. So in that case, LVAD is not helping for his recovery. LVAD was sort of prolonging his suffering. So in that sense, I think the LVAD therapy was, burdensome. That was the feeling we had with among the clinicians and also the families.
Yeah, and then another Mary, and I'm not even going to try to say her last name. I'll try, but I won't. You did talk about mental health and reaching these end of life decisions, and bringing in psychiatry. But when do you do that? Because it seemed like even in some of these cases, you could have done that earlier. How do you make those decisions about when to bring in psychiatry to see if the depression could be treated?
I mean, how do I say? I mean, if we want to treat the depression, yes. I mean, we call psychiatry. They are very helpful. But when patients express the desire to stop the LVAD, and I think, how do I say, the important thing is whether or not patient has decision-making capacity or not.
Mm-hmm.
And if patient has decision-making capacity, and then patient express that, I'm suffering, I don't want to go through the treatment. In other words, patient is not amenable to accommodate a psychiatric treatment with having a clear decision-making capacity. I think we cannot force the patient to wait.
Yeah. No. So thank you. Some people, there's some new messages on here. I don't think I'm going to get to all of them because we're out at the time. I think people, if you have the questions, I think the chat's really great. I'm sorry we didn't have enough time to get to them all. I do want to remind everybody that next month we will be having another seminar, and Jingjing Chang and her colleagues are going to be talking about palliative care in home health settings. And so there's a save the date. Also, people asked about whether your slides would be available. We will put this recording on the SIPC website. Bridget knows that. And so, if you don't know where our website is, contact Bridget at BAM 2233.
Yep, that's the one.
2233 at cumIC.columbia.edu. And there's so many people that are thanking you for such a thought-provoking and touching presentation. So thank you very much. Thanks a lot, Dr. Nakagawa.
Thank you.